So I'm happy to take questions, and hopefully we'll see many of you at different events or when we're visiting different institutions. It truly has been a passion of mine working on using radiation technologies to treat patients with liver cancer, and the majority of my research has actually been on hepatocellular carcinoma. And there really is a rising role, and I would argue established role of radiation to treat this cancer. So hepatocellular carcinoma, or HCC, is a very important cancer globally. There's more than 1 million cases per year. Still is one of the top causes of cancer mortality around the world and in certain pockets of North America, including Toronto. And it occurs on background of liver disease that can make it challenging to treat and the majority of patients unresectable. There are a variety of causes of liver cancer, and despite advances in hepatitis B vaccination, Hep C treatment, there's increasing causes of liver cancer, including metabolic-associated steatotic liver disease that is very, very common and on the rise in epidemic levels in the US. It requires a multidisciplinary team, and there are many different therapies and local regional therapies. And the goal is not only to treat the liver cancer, but preserve the liver function so patients can live and hopefully with high quality of life. So over the past few decades, radiation therapy has been perhaps one of the slowest therapies to be internationally accepted as a treatment. I'm happy to say in the last Barcelona classification system, or BCLC, which is internationally very well recognized, external beam radiation is now recognized. It's a first step, and these highlights actually show where in early stages it is recommended as a treatment. I hope to show you that, in fact, it is a treatment from early to advanced stage. And on the top of this slide, you can see the depiction of where the cancer is. The purple represents cancer, very small, single, or confined to liver in earlier stages, into the vein, or with outside of the liver, advanced stage, and very end stage, not suitable for any other therapy. And as you can tell, it's complicated, and there's many treatments with some benchmark survival in the dark blue over here. So historically, as I mentioned, the role of radiotherapy was low in hepatocellular carcinoma. It is now very effective for a wide range of reasons. One, we have a much better understanding of how to give radiation safely to the liver. We have better imaging and image guidance, methods of accounting for breathing motion, and our planning treatment is quite automated and faster, with higher levels of quality, not just confined to tertiary centers. And with personalized treatment and adaptive treatment planning, we even have further potential in the future to reduce the normal tissue volume irradiated to help these treatments be safer for our patients. There are many ways to give radiotherapy. I'm going to be focusing on external beam, predominantly stereotactic body radiotherapy. Proton radiotherapy has a strong clinical record in this cancer, as it can spare much liver with the dose deposition at depth and no fall off. And just a comment, and I'll give some evidence for this, that the role of external beam radiation is quite different than in other cancers, in that it can treat quite large tumors, including 20 centimeters tumors and above, and those with vascular invasion, as well as multifocal disease. It's outpatient, non-invasive. We've never had fiducials in our own institution as a method to treat patients. And although I'm not focusing on brachytherapy, there is a role, either interstitial, interluminal, and Y90, which we can discuss perhaps a little bit at the end, that is delivered through the hepatic arteries. A comment about adaptive radiotherapy: we have a joint collaboration between Odette and Princess Margaret and University of Toronto, so we'll be having hopefully opportunities to collaborate in the future, perhaps related to liver cancer, where we can use these two platforms that we both have, MR-based adaptation and cone beam CT-based adaptation, that really have potential to improve outcomes for liver cancer patients with better imaging, and also automated treatment with even a 6-second cone beam CT, allowing our treatment times to be quite shorter for our patients. And just to say, what does the future hold? Some say there's a platform and we've hit the elevation of technology. I would say I don't think so. This is maybe a little bit pie in the sky, but this recent paper in March of this year talked about AI end-to-end radiotherapy planning in treatment in under 1 second. So on the bed, treatment delivered. I don't think that will actually be practical for many cases in the near future, perhaps more to do to behavior and our inability to perhaps make decisions and want to pause when we do things. But it just shows the technologies are going to be there probably quicker than we're ready to accept. So we can have our treatments even be very fast in the future, perhaps even almost not even noticeable to patients in terms of number of visits and time on the table. So imaging is very important, as I mentioned, and that's probably one of the biggest advances that allowed us to treat patients. If we can't see the tumor, we are not going to be able to treat it effectively with radiotherapy. And this is multiphasic contrast imaging. That is really mandatory to best characterize the extent of hepatocellular carcinoma. And so this is an early phase. It generally enhances, but not always. And this is a venous phase where this is actually supposed to be vessels. So there's a space occupying lesion, the tumor in the vein. And for this particular patient with a delayed phase at 3 minutes, this is the same slice. You can see that there's actually involvement of almost the entire right lobe of the liver. That is not clear on a non-contrast or only arterial or only portal venous phase. So really important to have multiphasic IV contrast imaging. And sadly, many patients with these cancers are not diagnosed at early stage and sometimes may have a non-contrast or only a venous phase done sometimes in community where it's not apparent that there is a hepatocellular carcinoma. MR can also be very helpful for these patients. Just as for delineating tumor, imaging following treatment can also be a little bit challenging. There is LIRAD's standardized reporting now for a response following local regional therapy that is very helpful. Responses are not quick, and this is an example at 3 months and 9 months after SBRT, there still are changes within the liver, and those changes can change over time. That can make it somewhat confusing. I would just say caution not to overcall progression if changes happen, and there's not diagnostic hyper enhancing with fallout criteria for a true recurrence. So Canada has a big spot on the global stage for radiotherapy for hepatocellular carcinoma. I spent some time in Michigan where I had the opportunity to work with the team with advanced technologies in the late 1990s and came back in 2003 where launched many trials that some of you participated in, including early phase 1 studies of hypofractionated radiation, 6 fractions at first, then 5. Phase 2 studies looking at tumor-specific outcomes, phase 3 studies that I'll talk about a little bit today, some studies of combined modality therapy, including TKIs and immunotherapy, and more randomized studies that are ongoing now. It was always a very personalized program. It still is. One of the perhaps most personalized treatments we give as radiation oncologists, where the dose of radiation may be varied depending on the volume of liver that's spared, shown by this curve, and to its proximity, the tumor's proximity to different organs at risk, such as the bowel. And furthermore, we can adjust based on the inherent liver function. And the research programs, and even today, really have been built to adapt to technology. So as we have advances in the clinic and we can deliver radiation with smaller margins, the research programs and platforms were really designed in order to account for that and allow the implementation of technologies to the clinic quickly. So before I talk about the high precision curative role of radiation, I'm going to just have a comment on the palliative trial that we led in Canada. So for end stage patients, these patients really have no opportunity for any care. So patients who are refractory or unsuitable for therapy, either due to high burden of their cancer in the liver or due to very poor liver function that sometimes is a contraindication to treatment. Some of these patients do present with pain as the tumor may expand the capsule, and some have quite massive disease in the liver. So based on this, we led a randomized phase 3 study looking at very simple single fraction palliative radiation versus best supportive care to see if it could help cancer-related pain. I'll just comment that Hanny Solomon, when he was a resident, worked on the clinic trial before this, showing that in our single institution setting, we did see improvement in patient-reported pain with this simple intervention. So this was the schema. It was a randomized study. All patients had best supportive care, palliative care, analgesia. They had to have a minimum pain score of 4 out of 10, despite best analgesia and interventions that was reproducible. And these patients did receive antiemetic, dex, and granisetron or equivalent. The primary endpoint was day 30 patient-reported pain. There was allowance for crossover at that time if patients did not have radiotherapy, and then another assessment on day 90. So the study was positive. There was a statistically significant and clinically important improvement in majority of pain endpoints. Some are shown here. The primary endpoint was pain at worst using a BPI scale that was used for palliative bone metastases radiation trials. There was a sensitivity analysis where any missing data was assumed to be worse. And with that analysis, there continued to be statistical significance. So clearly showed in a randomized setting that radiation can help patients' pain. We did look at overall survival, mainly to make sure there wasn't a signal for toxicity, and in fact, the opposite was seen. With the intervention of radiotherapy, there was improved survival. And in the cohort of patients who had HCC, there was in fact a hazard ratio of 0.34 for improved overall survival. And this sets the backbone that perhaps the simple intervention could even be helpful in patients without pain. And Michael Yan at my institution is trying to launch a study really focusing on those patients where we can in fact perhaps offer these treatments to the patients who don't have pain but have non-treatable disease. This was one of the most satisfying trials I've ever led, even though it was very simple and it was palliative. There were a lot of positive notes from families and patients really appreciating the quality of life that they had near the end of their life. And so thank you to all of you who participated. It really was a Canadian effort to make this happen, including accrual during COVID. So moving to the other spectrum, very early stage, these are curable patients. Many patients aren't a candidate for surgery or for other ablative therapies. So I guess I would just mention external beam radiation is not only an alternative, but it is a desirable, excellent ablative treatment for HCC. And HCC is a radiation responsive tumor. It is not like a lymphoma, but it is far different like a colorectal metastases that is very hard to treat, where responses are and sustained responses are only seen with very high doses. This is one randomized study. So this is looking at thermal radiofrequency ablation compared to stereotactic body radiotherapy delivered in 3 fractions in 166 hepatocellular carcinoma patients with tumors that are 5 centimeters or less that were recurrent following prior therapies. And there was a statistically significant improvement in local progression-free survival with 2-year local progression-free survival, 92% for those patients treated with radiotherapy, shown in yellow, versus 84 for those treated with RFA. And they had similar survival and excellent survival, 2-year overall survival, 98% with SBRT, as you can see with the curve on the right. And there are indeed progression. And so many patients who have one hepatocellular carcinoma, especially a recurrent cancer, are at high risk of having another one or other foci of cancer develop. And you could see that it was slightly more likely in patients who had tumors that were larger in size. This is another randomized study. I won't go into the details. It was with proton radiotherapy that showed similar non-inferiority for radiotherapy compared to thermal ablation. Looking at our own outcomes, we pooled data with the University of Michigan. These were more advanced patients with a poor performance status, real-world data, not a randomized study, over 300 patients, and many who had poor liver function, and these were far larger than the tumors in the prior randomized studies, with a quarter of patients having tumors greater than 5 centimeters up to 18 centimeters. There also was some inclusion of patients who had poor liver function. The bottom line is, even with modest doses, slightly lower than the randomized studies, the median was 40 gray in 5 fractions. The doses ranged from 30 to 60 in 3 to 5 fractions. The 5-year local control was 86%. So the majority of patients with controlled tumors at 2 years have sustained control. Looking at size, there was better local control if the tumors were 5 centimeters or less, 90%, but still very respectable at 80% for those tumors that were greater than 5 centimeters, including those that were subgrouped a little bit at the higher cohort in red. Interestingly, when we could treat with breath hold, the local control was better, showing perhaps a surrogate for advanced technologies making a difference. So what about transplant? So the best treatment for patients with liver cancer is liver transplant, and that treats the underlying liver disease as well as the tumor. But only patients with small tumors, relatively small tumors, are eligible. In Toronto, that's up to a 6.5 centimeter sphere, or the equivalent volume. That is the total volume that must be lower in order to have patients have transplant. So the majority don't have tumors at transplant. Some do, and we would consider them, and some can become eligible for transplant. And radiation can play an important role for these patients. This is a patient I met during COVID, and she had very poor liver function, as indicated by a Child-Pugh score B9, so something we usually don't treat patients with that poor score. She was on the transplant awaiting a liver, but then became off the list because of her tumor growing. So her tumor not only grew in volume, but her tumor marker, the alpha-fetoprotein, rose from under 1,000 to then 1,700 to then over 4,000, at which point she came off the trial. But she continued to have one tumor. And it was COVID. This is the time when we had a decreased footprint. This was actually the first patient I treated with single fraction. I would call this quite gentle SBRT, did not necessarily think it was ablative. We used 16 gray and 1 to this tumor. And very quickly after her treatment, her tumor marker went down to normal, 8.8 from over 4,000. And she became listed again and did ultimately have a live donor transplant. She had a pathological complete response of her hepatocellular carcinoma, but did have a component of cholangiocarcinoma that was seen and was still viable. Fortunately, many years later, she's still doing well with no evidence of cancer. So even low dose simple radiation can help some patients be ultimately cured. Looking at all of our outcomes in Toronto, this is 88 patients who were bridged or treated with radiotherapy that ultimately shrank the tumor, allowing a patient to have transplant. We've found, and we've published previously, that this is safe treatment. There is indeed fibrosis if the tumor is at the edge or caudate or the portal area of the tumor, of the liver. But that is something that, with communication with transplanters, can be dealt with no increased risks in terms of objective measures. And looking at this modest doses, 30 gray and 5 to 6 fractions in patients who were bridged, so the majority, 58 patients, had the median tumor diameter of 4.3, and those who were downstaged, this is a term they use in HCC world, so the median diameter of those tumors were 7 centimeters. We did find that there was no increased toxicity and that the probability of getting a liver transplant was about 60% at 12 months. So the majority did get onto the liver transplant. There was no substantial toxicity. And overall, the survival was excellent. So if we look here at those patients who were transplanted, the 5-year overall survival is 83%, similar to other bridging therapies. And in terms of the recurrence risk, it's quite low. It was higher for patients who were down staged, who had larger tumors, but still, this is 3-year mark, you can see 75% had not recurred. So a good treatment, even in patients with poor liver function. I will just highlight, we have a few active trials in those patients who may be candidates for transplant. One is looking at immunotherapy in resectable HCC, so this is actually not transplant, but surgical patients. And then for the transplant patients, there is a trial looking again at atezo-bev, an immunotherapy standard treatment for advanced patients who have large tumors and then taken them to transplant. There's more risks with immunotherapy, but this is being done on a prospective study. And finally, for patients who aren't eligible and some who have quite advanced disease, even invasion into the vein, if they have sustained response and complete response in the vasculature from stereotactic body radiation or yttrium-90, they then may get immunotherapy followed by transplant. So this is an active study, and just keep it in mind with your patients, even if someone who originally was not eligible for transplant, they may become eligible after treatment, and or you could prefer for possible participation in such studies for patients who are interested. So intermediate stages is a bit blurring in a lot of literature, but multifocal tumors often treated with regional therapies. What is the role for radiation? Well, there have been randomized studies. This is a small study of proton radiotherapy in 15 fractions versus TACE, transarterial chemoembolization, standard treatment for these lesions at the time. This is pre-TKI, pre-immunotherapy era. There was increased local control with radiotherapy shown in yellow, and there was also increased progression-free survival with less cost and a higher chance of pathological complete response following radiotherapy. Some of these patients were ultimately transplanted, and that was the bigger driver of survival. And so there was similar survival for both of these treatment arms in this group of patients. There have been multiple small randomized studies of SBRT versus TACE, and they've similarly shown improved local control, as you can see in this curve on the right from a study done in Italy, and improved progression-free survival compared to TACE alone. And other studies have shown similar from Netherlands, for example. Looking at large data sets, this is a look at randomized studies for HCC patients, including over 11,000 patients. And 6 of these randomized studies did look at radiotherapy. And overall, the bottom line is that progression-free survival and overall survival appear to be improved when radiation is used versus anything, versus systemic therapy with a TKI, that's sorafenib or lenvatinib, and versus TACE. And you can see in these graphs with progression-free survival and overall survival that when looking overall, there actually is statistical significance of improved not only progression-free survival, but overall survival with external beam radiation. And that wasn't the case with all local regional therapies such as Y90 or TARE, as you can see below. I do want to just comment on large tumors. Some people don't understand that even tumors 15 centimeters, 20 centimeters may be curative with external beam radiation, and indeed they may have cure. So this is a large series looking at 1,800 patients who were treated with proton radiotherapy in approximately 4 weeks. And the 2-year failure from local progression was 90%. You can see in the curve, even at 3 years, 4 years, there are very few patients who recur. So excellent local control, even in the large tumors. So the different colors represent larger tumors. Gray is between 5 and 10 centimeters, and red is tumors over 10 centimeters. We do see worse survival as the tumor size increases, as you can see on the right. And that's not surprising, as there's a higher risk of invasion into the vessels with larger size, and more motivation for combined modality studies for large tumors to treat that hidden microscopic disease for sure. In North America, this is a recent study, and I just highlighted similarly excellent local control, few local recurrences. Overall survival in this group is less than the large proton series, but this is a group of patients who had vascular invasion and very poor liver function in about a quarter. The median tumor size was 9.2 centimeters up to 20 centimeters. And I think there's a few interesting lessons from this paper that is just about to be published in Red Journal. And one is, and you look at this Venn diagram, it is quite uncommon to have a local recurrence as the only local failure. So in this case, only 3 patients, or 8%, presented with a local only recurrence. The other thing was, despite treatment with patients with poor liver function, it was very well tolerated. So there was actually, this is mixed up, sorry, there was 6% liver toxicity in Child-Pugh A versus 15% in Child-Pugh B patients. And as I mentioned before, with large tumors, and especially with invasion into the vasculature, high risk of there being microscopic disease. So the progression-free survival is not as good as in those patients that have small tumors in the other trials I showed. So what about photons? So we at Odette and Princess Margaret don't have protons or access to protons yet. And photon external beam therapy is also extremely effective. So this is some outcomes for some of the tumors that we've treated, including the first line, one of our early phase studies, where we used 6-fraction SBRT ranging from 30 to 54 gray in size, with a median tumor size of 7.2. and tumors up to 23 centimeters treated. And we found 1-year local control of 87%. Similar other groups, including this one from BC, showed that in these very large tumors up to 10 centimeters, local control was 92%. And then finally, different series. One is combined modality, showing up to 25.7 centimeters local control at 2 years, 75%, and 72%, and 3-year local control, 82% in this paper by Co. There's exponential reduction in tumor marker in our own series, and you can see even consistent with others. Most patients are stable, even if they haven't responded. And as I mentioned, many of this is for sustained. So even photons without protons can treat very large tumors with curative intent. Another therapy, another way to give radiation is with the hepatic arterial radioembolization, or yttrium-90. It's different, as we know in radiation oncology, than how we deliver external beam. There's some advantages of external beam, and there's some advantages of Y90. This is my own sort of way I think about things, is how we deliver, why we might choose one treatment or the other. There's more uncertainty in dosimetry with Y90 and more chance of having cool spots, especially for large tumors. So it's more effective for smaller tumors, less of a role for larger tumors. The Y90 alternatively may be better for multifocal or small lobar lesion that we couldn't spare liver for with external beam. Both can be used for downstaging and for in the transplant setting. Randomized studies that I will show actually improved survival, especially for advanced patients. But there is often a decision in clinic, like what is better than the other. And I'm happy to say we do have an open randomized study that may help to answer that question. This is led locally by Dr. Michael Yan. It's called Socrates, and it's a randomized study of interventional radiology, directed therapies versus external beam. And in the cohort of patients with 5 to 8 centimeter HCCs, the randomization that we will be looking at is SBRT versus Y90. So we just opened that study. I think the activation is today or tomorrow. And so if you do have patients interested in the study, please don't hesitate to reach out. We'd be happy to see them and consider them if they are interested. So moving to advanced stage, this is in fact the great majority of the patients who I see in my clinic. And this generally refers to patients who have invasion of their cancer into the vasculature. That may be the portal vasculature draining the gut, or the hepatic vein going to the IVC to the heart. This is a very poor prognostic factor, and that's why it is an advanced stage. In fact, it's pooled with external metastases in the BCLC system. The degree of macrovascular invasion is important. With more central and more occlusive involvement, the prognosis is poor. No matter what therapy is delivered, including surgery, the outcomes are worse. There's a high degree of diffuse microscopic disease that we may not see. And invasion into the portal vein itself can block the flow of blood, increase the portal pressure, and lead to a decline in liver function from the cancer. So very tough situation. There's grading systems. The BP 1 through 5 is used routinely. We can also grade the degree of hepatic vein involvement. And in the earlier stage, there are better outcomes than in the later stages, the BP4. BP4, or involvement of the portal vein, is generally been excluded from Y90 trials, local regional trials, and up until recently, most of the systemic therapy trials. Of note, it has not been excluded from the external beam radiotherapy trials. So there is rationale for systemic therapy, given how poor prognosis this situation is. But unfortunately, many patients with poor liver function, or who may not have objective responses to systemic therapy, outcomes are very, very poor with systemic therapy alone. So there's strong rationale for combined modality. First comment is that external beam radiation is effective for treating hepatocellular carcinoma with macrovascular invasion. And this is from the same group that I showed before, the 1,800, so over 1,800 patients, but broken up by stage. So the BCLC-C in red shows the freedom from local progression. And again, despite being in the vein, radiotherapy can control the tumor where the beam is aimed. And not surprisingly, when there's involvement of the vein, the prognosis is poor, or worse than those who do not have involvement of the vein. Saying that, this median survival with involvement of the vein is actually better than what was seen for other therapies at the time, where it is around the 18-month mark. The 2-year failure from local progression is about 90% across all subgroups, including if it's in the vein. So definitely something where radiation has a strong role. This is an example of 2 patients treated who had sustained control of their cancer. One had Hep C, one had Hep B. They both had macrovascular invasion, hard to see, but into the right portal vein. The 6-month scans are shown here. The 4-month scans can show on the top patient there was almost a hepatectomy with fibrosis of the right liver from the high dose to the majority of the right liver. But the untreated liver hypertrophied, we see this as you do with other local therapies. And the patient actually had good liver function for many years after his therapy with no systemic therapy. So good news, we can control these patients. This was unfounded or unheard of for at the time that we did publish this. Most patients did die, sadly, within months or years. So long-term survival is possible. However, as we have more patients with long-term survival, we did find that there is the potential for late recurrence. So at 78 and 73 months, these two patients did ultimately have recurrence within the vein. So this means we need to continue to follow our patients more than 5 years. And also, the fact that late recurrences happen and shows us that dormancy happens in HCC, what triggers the regrowth. We need to do some studies here. And we need to maybe think about how do we improve a sustained cure, do combine modality for these patients, or do we consider treatments like transplant when someone has been control of their disease for many years before there's more diffuse incurable progression. So there are many randomized in the advanced setting, many randomized studies. And so these are a list of 4 randomized studies that have all shown impressive improvements in outcomes, including survival with radiotherapy. And of these studies have shown improved progression-free survival, time to progression, and overall survival, quality of life. The first looked at neoadjuvant radiotherapy and surgery and actually showed improved survival with surgery. This is from an Asian group. And the second looked at radiotherapy delivered in 15 fractions with TACE, showing that it was improved compared to sorafenib, that was standard of care at the time. I'm not going to show these studies. These are all just included patients with macrovascular invasion, such as shown here in the schematic. I'm going to describe to you the RTOG study that we led here, and then briefly talk about another study that looks at radiation and immunotherapy from Asia that is very provocative outcomes. So the Energy RTOG 1112 study was a randomized study that looked at the addition of personalized SBRT to sorafenib alone for patients who had locally advanced hepatocellular carcinoma that was not suitable for standard care treatment. And that at the time was TACE, RFA, surgery, transplant. These patients had to have a tumor, sum of diameter or single tumor less than 20 centimeters in size. There had to be less than 5 or less foci of cancer. Any degree of vascular invasion was permitted, and that was a stratification factor, and a small degree of metastases was permitted. They had to be eligible for the systemic therapy, sorafenib, that was standard of care, which meant they had to have good liver function, Child-Pugh-A. We also stratified by the site, North American or not, the burden of disease, the underlying liver disease, and as I mentioned, the degree of invasion into the vasculature. It was a 1-to-1 randomization, and the dose of radiation ranged from 27.5 to 50 gram 5 to the PTV. In the SBRT arm, it was sequential. So following SBRT, half dose sorafenib was used for 4 weeks and then escalated up to full dose when tolerable. These are some of the key eligibility, just clarifying what I mentioned before. Much of the biochemical eligibility was for the TKI. So eligible for systemic therapy meant platelets had to be above 60,000 and good liver function, relatively good liver function. They also couldn't have had a major bleed within 30 days of randomization. This study did stop early as the standard of care changed during the study. And despite that, the stats were adjusted to look at events. And we then presented the studies at that time of readout. So in the patients treated, there were majority of patients had advanced cancers, not surprisingly, with a median diameter of 7.8 centimeters up to 19 centimeters. And looking at different factors here, 41% had Hep C. The majority had multiple tumors, and 3/4 had macrovascular invasion. And of those patients, the great majority had involvement of the main portal vein or main or right portal vein, very poor prognostic patients. In fact, 64 and 62% had involvement of the main vein. as mentioned, the radiotherapy was personalized. And so it was based on the mean dose to the liver. And happy to take questions of why that was. It was a way that we could personalize that was simple in a cooperative group study based on some of our own experience of how we personalize doses based on the effective liver volume irradiated. These are three typical plans. So large tumors, as you could see, some with low doses if abutting luminal structures, 30 gram 5, and multifocal tumors perhaps treated to different doses permitted as well. In the sorafenib arm, 21% ultimately received SBRT at the time that they became ineligible for sorafenib or progressed due to either had toxicities or had progression. And in the SBRT arm, the majority of patients had radiation as prescribed, although some patients actually had decline in liver function or progression even before radiation could be completed. So looking here, 3 patients had low doses, as you could see, and the median dose was modest. It was 35 gram 5 fractions. So as seen here, 30 or 35 gray, 30 to 45 gray, the most common regimens used. The median overall survival was improved with radiotherapy from a median of 12.3 to 15.8 months, as you can see in the survival curve. And when looking at an a priori multivariable analysis with the prognostic factors of performance status, presence of metastases, Child-Pugh A6 versus A5, and the degree of macrovascular invasion, there was a p-value of 0.042, hazard ratio of 0.72, which is what we had hypothesized for improved survival with radiotherapy. Looking at a forest plot of the different subgroups, a little bit tricky to see, but you can see the majority do have improved outcomes with the addition of SBRT. And in this highlighted bit here, this is the vascular invasion involving the main right or left portal vein, or the IVC, so BP34 or IVC. And in this subgroup of patients, the majority of patients, the 2-year survival was quite substantially improved with radiotherapy. So 8.8% versus 28% with the addition of SBRT. And I would argue that this is probably the subgroup where the biggest gain from this randomized study happened. Similarly, there was improvement of progression-free survival and time to progression with statistical significance and clinical relevance. And adverse events were similar. Not looking at attribution, about 3/4 of patients had any grade 3 or higher events. That is common from these patients with sorafenib. It's common in these patients even with no therapy due to their cancer. It can sometimes be quite difficult to attribute adverse events either to an intervention, the cancer, or cirrhosis. There was no signal for worse events with SBRT. In fact, there was less GI events, as shown in this slide, with the addition of SBRT. And when we look at the attributable events, similarly, no signal of worse toxicity, really showing us that the majority of the adverse events are due to the cancer itself. And if we can control the tumor, patients, in fact, can feel better. And in a subset of patients who did complete patient-reported PACT quality of life surveys, there is the demonstration of improved quality of life at 6 months in the SBRT patients, as you can see with the green proportion on the pie chart, compared to far more patients who had worsening of quality of life in a statistical manner at 6 months who had sorafenib alone. And for any of those interested, there's some letters to the editor talking about the statistics and the probability of SBRT improving survival being quite high. And so I encourage you to look at them. So the standard of care for systemic therapy has changed from TKI or sorafenib to immunotherapy. So the question is now, is there a role for SBRT? And I would say definitely yes. First thing is not all patients are eligible for immunotherapy. Some have contraindications, autoimmune disease, poor liver function, bleeding. Many parts of the world, it's not affordable. There are delays in IO sometimes, depending on if there's a chair available. In some regimens, variceal blending might be needed. And finally, in patients who do have a good response to immunotherapy, most are considered for TKI therapy as second line, and they may still be eligible for SBRT, similar to the RTOG 1112 eligibility. I would advocate to consider radiotherapy as per RTOG in those patients. But I will say upfront, randomized trials of immunotherapy and radiation are warranted. So we have done some studies looking at the combinations of different IO with radiation as others have. This is our study looking at pembrolizumab and radiation in patients who had refractory hepatocellular carcinoma despite being treated with TKI. And in this group of patients, we found this was safe. The median overall survival was 12 months, included 45% of patients who had macrovascular invasion and one with a complete response. Some patients did it very, very well. And similarly, others have shown safety of different combinations. I'll give you one example of a patient who was seen with a 17-centimeter tumor, as you could see here on these cuts. He had a tumor invading the hepatic vein, portal vein. The tumor ruptured. The liver function worsened. This sadly is not an unusual story. Not eligible for any other therapy. Treated with 27.5 and 5, so similar to RTOG, the lowest dose that we used. A palliative dose, but still safe in these very large tumors. And we did ultimately see that this patient had a response at 3 months, as you can see, less viable tumor at 6 months sustained with far less cancer into the heart, into the IVC. The patient ultimately had improvement of liver function and could have immunotherapy, a good way to combine treatments. There is the randomized study looking at a combination of a checkpoint inhibitor with radiation from Asia versus sorafenib. This is small numbers, was presented at ASTRO, is not in publication yet, and it was only for patients with substantial vascular invasion, VP3-4. But interestingly, the survival curve is very marked in terms of the benefit with radiation and immunotherapy versus sorafenib, showing safety and a signal that this may be a very important regimen. So based on this and other papers, we have launched energy study GI012 Helios, and I believe you're going to open at your center. I hope so. We have just activated it at our center. And this study is similar to RTOG study, a little more pragmatic. It includes patients with Child-Pugh B7 liver function, and the eligibility is that any degree of macrovascular invasion is required. They cannot have had any prior immunotherapy, and will be randomizing patients to any standard of care immunotherapy regimen, plus or minus SBRT. And so there's 3 regimens that are approved in Ontario: Atezo-Bev, Stride, and Ipi-Nivo. And that can be the medical oncologist decision of what to use. There's typical stratification factors. It's a 1-to-1 randomization. The primary endpoint is survival. Even though there's now second-line therapies available, we do believe upfront radiation should improve survival, given by some of the studies I've shown. So what about SBRT for oligo progression? So this is a different group. These are patients who are already on IO. I think this is a strong role for radiation. It warrants trials. This is one small study looking at radiotherapy in patients who have one site of progression and a site of metastases after being on immunotherapy. The general prognosis of these patients is not great. These patients continued with their immunotherapy and excellent overall survival. The mean is 34 months. So these patients are living a long time on the same first-line immunotherapy regimen, where usually within 6 months, these patients would have had a different regimen and been off immunotherapy. So much better outcomes than expected with radiation in this setting. So a good other group to consider: radiation and perhaps clinical trials. Before I wind up, I will say this is a paper that is in press in JCO. We participated with others, and it's just a very large cohort of patients, almost 5,000 individual patient data looked at. It's in collaboration with the BCLC group, really asking us to try to show us in a large scale what our outcomes are across all stages of tumor. And these outcomes show survival in all patients at the top, treatment-naive patients in the bottom, different external beam radiation, protons and photons. And on the right, if you look, these median survivals are years. This is the 3-year curve here. So for early stage median survival, 6.8 months, 4.6, 3.6, even better in the treatment-naive groups, really just confirming in large-scale multi-center study, these outcomes rival other treatments, including surgery. Worse outcomes with Child-Pugh C, but again, a median survival of 1.7 and 1.5 months in this large database. Again, better outcomes than what we see with most systemic therapies. So in conclusion, radiation therapy is indeed a very effective local therapy for hepatocellular carcinoma, including for very large tumors and including for even invasion into the proximal portal vein. Randomized trials showed improved outcomes, including survival. There are many open clinical trials and many opportunities for further trials. I encourage you to open Energy GI 11 and 12. I hope you will, with the combination of radiation and immunotherapy. I think we do need this to better establish the role of radiation up front, as outcomes are also much improved with immunotherapy compared to TKI. As I mentioned, we have an SBRT versus Y90 study, so please consider sending patients to us for that. That hopefully will provide some information, but probably and possibly there are even opportunities to study combination in very large tumors. And finally, as I mentioned, SBRT for oligomets an interesting setting, and we desperately need biomarkers and better understanding of whether we've ablated, when we need combined modality therapies, et cetera. So it's a great field with lots of opportunities for research. And just finally, many students rather and collaborators have contributed. And so thank you to everyone who helped with slides. And I think I've left some time for questions, so I'm happy to take any questions. Thank you very much.
Thank you, Dr. Dawson, for the excellent presentation, which demonstrated the broad bandwidth of SBRT in the treatment of HCC. While we await, questions to trickle in, I'm going to start with some questions, Laura. So I'd like to talk a little bit more about Y90. Some practitioners, generally favor Y90 over SBRT, citing that a much higher radiation dose can be delivered with Y90 compared to SBRT. For our colleagues who are outside of the specialty, perhaps you can elaborate on the differences between the two radiation-based modalities and why we cannot simply compare the numeric dose.
Yeah. It's apples to oranges. So the way we describe dose, the way we deliver dose, and the way the dose is deposited is very different. And as you could see from the data I showed, the kind of doses with very sustained local control and ablation are not the highest we can deliver. So 30, 35 gram 5 fractions, as you know, are almost half, what we can give or what we do give for very small tumors or lung cancers. And so there is not a need to give extremely high doses. There may be increasing benefits, and that may be from 85% to 95% local control at 5 to 10 years for large tumors. So for large tumors, there may be gains to dose escalation, but not a need for 100 or 200 gray, et cetera. So that's, I guess, the first thing. So we have the clinical data that you do not need high doses. We have more certainty in where the doses are with external beam, so we know what is covered. And as you know, the dose, when we say dose, this is a prescribed dose. We talk about it as a prescribed dose to most of the PTV, but there may be heterogeneity in dose in what we deliver, but we really focus on the minimum dose and that we want to make sure there's not a cold spot or a spot of the tumor where there's no dose. So, so that's, as you know, external beam. So yttrium 90, so deposited with very short fall off, which is the advantage at the edge of the tumor in that there's very much sparing of normal tissues at the edge of the tumor. But as it's deposited through the hepatic artery, there's expertise from interventional radiologists that allow it to be delivered selectively to the tumor, which is very important. But there's also some randomness, and that is in terms of where the beads are deposited. And the larger the tumor, the more randomness there is, with more chance of them not being deposited equally and more chance of a cool spot. And as we know in our field, even a very small cool spot, even if most of the tumor is getting very, very high dose, we believe it usually drives recurrence. And I think that is why some of the series of large tumors have shown recurrences with Y90, and also that some of the trials haven't shown improved overall survival. With Y90, those trials that were negative, they were in era without modern dosimetry, and there's a learning curve. And there's some patients who just vascularly aren't, there's a fall off. So even if someone is randomized to Y90, sometimes it's not possible to treat the whole tumor. So there's all kinds of reasons why those studies are negative, and there's definitely promise with dosimetry with Y90, with improved personalized dosimetry, where there'd be more ability to know who is going to have more likelihood of full coverage or not. But anyway, they have the doses, and the doses of the highest spot or the highest, like what we do with brachytherapy, the very high spot, we don't record that, only that doesn't actually tell us what the minimum dose to the tumor. So yeah, they're different, and we just have to recognize they're different, and we probably can work together to hopefully describe in more similar manners the full coverage of the tumor and learn, what we need to have ablation, which is what we're usually trying for with both modalities.
Yeah, the Socrates trial is certainly very timely. Look forward to the results.
Yeah.
Now, there's a follow-up question to that. How about brachytherapy versus SBRT? Are there any studies comparing them?
I don't know of any randomized studies. There are some expert centers who treat HCC with percutaneous brachytherapy. That might be Amand who asked that. So I know excellent group in Germany who have MR-guided percutaneous brachytherapy. I find it shocking that this is effective. The outcomes are good. It's a very specialized center. It's an interventional radiology, radiation oncology collaboration. Clearly needs to have very strong collaboration to make that possible. The disadvantage is a needle from the outside. The advantages, when I speak to that group, Ronke is the IR, is that, well, if you're already going to put a needle in, why not give radiation where you can treat larger tumors and be more effective? But there is some risk. So in patients who have low platelets, poor liver function, propensity to bleeding, treating the tumor in vain, there are more risks. And probably quite a specialized team would be required to treat that. Small tumors, it's something that's possible, and sort of as if you're going to do a thermal ablation, why not give radiation there? So there's not many. Your center has some experience with percutaneous brachytherapy. We do not do that, and it's actually pretty limited the number of centers who have experience, but it is a means to do it. For cholangio, the intraluminal is a nice way to give radiation, but very technically challenging as well.
Indeed. Um, let's see. Thank you for your wonderful talk. Can you share strategies on how to advance for SBRT in SBRT skeptic environments?
Yeah, it's a good question. It's I think for a lot of local regional therapies, it was slow for the hepatology community to accept our treatments. Maybe it's easier to understand a systemic therapy trial. That's positive, and that changes evidence. We talked about Y90 versus TARE. Y90, it took actually transplant, took a long time for transplant to be accepted as a treatment, and also Y90, and just a little bit longer for external beam radiation. I think one is being at the plate, um, being aware of the data. So I emphasize a little bit of this talk, large tumors, because I think it's hard to sometimes know where radiation may have a role if you're not aware that there are good outcomes in large tumors. So I think, advocating, working together, participating in trials, recognizing our treatment's not perfect. There's disadvantages to our tumors. Like to our treatment, when a cancer is budding or invading the stomach, harder for us to treat, more risk of there potentially being an injury to the stomach. So, work with colleagues, know the evidence. I can share my slides and participate in trials and be patient. I guess that's one thing.
What is your experience with treating an HCC with SBRT after prior Y90 with respect to efficacy and safety?
So I don't have an extensive experience. Some of our colleagues in the US do, because as you mentioned, there's a large popularity of Y90. So there's a few centers like at Mount Sinai who I've been told almost all patients have had prior 90 before they come to external beam. I'll speak first from my own experience. My own experience, and again, it's very hard. We only see those who recur. We don't see the denominator. Before we had Y90 here, mostly, I would say, I did have some patients who were treated in US who ultimately recurred for the reasons I said. Either anatomically, it wasn't possible to deliver the Y90 to the full tumor, or patients just had large tumors that recurred quickly. So we have done it in selective situations. A little more commonly now, maybe in our group, maybe a handful, like not a lot, but maybe 5 or 10 patients we've done it. We're very cautious. I'm personally probably more cautious than needed. I think the first thing is communicate if you can with the interventional radiologist who delivered. If there's dosimetry, terrific. You may have a good idea of what was treated or not, which can help you deliver doses safely. If you know part of the tumor was completely not treated and that's what grew, then we know you can give near full doses there. But also to know, what happened, and I think, and it wasn't super selective, etc. Those kind of things matter a lot. It's often not the liver that is at risk with repeat radiation. It's the structures that are close to what was treated. And my colleagues at Sinai and others have said to me, it's fine, it's safe. You almost don't need to consider it. But you have to remember, even with Y90, there is several millimeter of dose fall off. So if the tumor originally was abutting the duodenum, there was some dose there. So that's how we consider it. So carefully, and there, the one study from Stanford did show increased toxicity when there was the combination, more than you would expect. So I think Alera, if the goal is to cure the cancer and this is the only therapy that can do it, you want to give some type of dose that has the chance to do that, but it need not be 6 gray and 3 fractions. You could probably give 27.5 or 30 gray covering the PTV, maybe escalate to the tumor away from the OIR and use doses and you be very thoughtful about the adjacent OIR. So that I don't have enough to give you like evidence-based from our own experience, just that definitely work together. Some of these patients can be salvaged and knock on wood, we haven't seen toxicity yet but being very cautious.
As one last question. So, a patient's underlying liver function is an important factor to consider when we decide on what treatment is appropriate for HCC. For SBRT, what are your thoughts on some strategies that have the potential to improve the therapeutic ratio of SBRT? You mentioned earlier that maybe combining with immunotherapy. What are your thoughts on using a pulsar approach? For example, in the Child-Pugh B patients.
Yeah, so B7, so it's a very good point. The liver function can drive survival and risk. And, an aspirin can trigger someone into liver failure who has B8 disease for those who don't treat HCC. So you do have to be very cautious and cognizant of what the liver function and including also low platelet counts, which is common in many patients, even with Child-Pugh A5 cirrhosis. So patients who have poor liver function, you must be more careful. So in general, B8 or higher, I would say is an exclusion for curative intent SBRT, with the exception of bridge transplant or someone who might get to transplant or someone needs palliation where you might give single fraction. But that's a big group of patients, B8 or higher, who don't have standard therapies and their chances of declining liver function are high. So that would be the group of patients I would suggest to focus on for novel approaches on a trial, such as Pulsar. For patients, B7 is a spectrum too. So there's some worse and there's some good, but some of them are curative, very high chance of cure with our therapies for smaller tumors, very likelihood of cure without a declining liver function. So I would not have experimental therapies there. I would be de-escalating therapies a little bit there. Perhaps one way to do that is by pulsing out and giving slowly so that, possibly, but if there's a chance for cure, we don't know necessarily that that's a curative therapy. So I'd be very cautious, but maybe on a trial, I myself would not touch that with the Child-Pugh A patients. But in that Child-Pugh B8 and higher, it's one of the kind of approaches that might work. And it gives the test of time. So it is consistent with, testing how can this patient tolerate a single fraction that might have some benefit on its own before giving the next regimen. So I think there are many with very enthusiastic about that approach. So I really look forward to the trials and seeing how it can work on a trial.
Likewise. I think that sums up the presentation and the question period today. Thank you so much for your time, Dr. Dawson.
You're welcome. And I'm happy to have people reach out, email or text or questions, even before referring patients to talk. You don't necessarily need to refer a patient if you wanted to know about a study. We can check if a study's open or not and work with you. And hopefully you'll open some of the trials at your center too, like the GI 012. So thank you very much for letting me have this chance. It was a pleasure.
Thank you. Thank you everyone for attending. Have a good afternoon.